Facebook, perhaps if you, sorry, to YouTube, if you want to introduce.
Perfect. Yeah, sounds good. So welcome guys to your PLAB teaching webinar. So as you can see, today's topics, we're going to be talking about hyponatraemia and hypercalcaemia in line with the current UK NICE guidelines. I can see lots of you logging in already. I think there was about 370 sort of sign-ups. I can see 46 of you have now logged in within about 1 or 2 minutes, which is good. So we're going to be live streaming as well to the iMedix YouTube channel. So if you are joining us, you can see it live on the YouTube channel. And it will also remain on the YouTube channel. So if you want to watch it back later on, you can watch it back as many times as you like. So do let us know whereabouts in the world you're joining us from, what time it is, and obviously what the temperature is. We're based in the UK, based in a city called Coventry, not far from Birmingham. It's a cloudy day. It's about 4 o'clock in the UK now. Not sure exactly what the temperature is. I'm sure Moira will correct me. It feels like about maybe 10, 12 degrees. But so whereabouts are you guys? We'll give you a shout out. Tell us where you are, which country you're joining us from, what time it is, and what the weather's like. While Dr. Mo obviously gets the stream ready in the background. And obviously we'll give you a shout out. So a nice bit of the presentation. So we've got Innocent, welcome Innocent, good to hear from you, Innocent. So Innocent's from Nigeria and it's 4:03 p.m. So basically the timing in Nigeria is exactly the same as the UK because the UK clocks went, I think they went forward only a month, roughly a month ago. We've got Sadia who's joining us from London. Welcome Sadia. We've got YK who's joining us from Nigeria in Abuja specifically, and it's 38 degrees. Wow, it's scorching hot there. So obviously it's a lot hotter there than it is here. We've got Harini who's joining us from India, and it's 8:30 p.m. So welcome Harini. So it's quite early evening there at the moment. We've got Ayinti who's joining us from Jebin, Lagos in Nigeria, where it's a very sunny day. We've got Abinya from India, again 8:30. Welcome Abinya. Or Abinaya rather, so forgive me if we pronounce your names incorrectly. Salome from Uganda, and it's 6:03. We've got Mohammed from Tamil Nadu, India, and it's 8:30 there. Hajira Bibi from Geo, I think that might mean Georgia, I'm not sure, but it's 7:04 p.m. there. We've got Sumaya from London. We've got Priscilla from Ukraine, and it's 4:06 there, so a couple of hours ahead of us than the UK. We've got Jitu from Kerala, India, and it's 8:30 there. We've got Lydia from Doncaster, which is of course in the UK. We've got Daniela from Tirana, Albania, and it's 5 o'clock there, so about an hour ahead in Albania. We've got Chukwudi from I think it says Judy, Saudi Arabia. So it's 6:04 in Saudi Arabia. So again, only a couple of hours ahead of us in the UK at the moment. We've got Tunde, who's from Nigeria, and it's again a very sunny day in Nigeria, and it's 4:04. Shanten Naidu from South Africa, and again it's 5:04 there, so about an hour ahead of us in the UK. Andrew Jackson from Wakefield, and it's freezing. Oh, it is freezing compared to all of those exotic destinations and high temperatures that we've seen from all the other people joining us. So I agree with you. Wakefield is up north from what I remember, in north of the UK. So obviously it's normally a bit colder up there anyway. Coventry's based in the Midlands, which is not far from the second biggest city in the UK, which is Birmingham. We've got Mary who's joining us from Iran. Welcome Mary. Andrew again says it's freezing. I understand, I feel your pain, Andrew. We've got Adu Bowden from Lagos in Nigeria, where it's again 4:05 p.m. Mary says it's 7:35 at the moment in Iran, so about 3.5 hours ahead of the UK. Aduban says it's very hot where he's based at the moment. Nyla rather from Canada, it's 11 a.m. in the morning. Okay, that's interesting. So quite early start to your day at the moment. It's 7 degrees, so that's pretty chilly as well there in Canada. So a bit cold there. So let us know, guys, if you want us to give us a quick shout out. We're pretty much going to be live. I think Dr. Mo will be ready as well. I can see lots of you are now logged in, which is great. We've got another shout out coming in. So we've got Abiodun from Namibia, and it's Namibia in Africa. So it's 5:06 there. So about an hour, roughly an hour ahead of the UK as well. So welcome, Abiodun. It's great to see so many people joining us from different parts of the world. As always, the iMedix PLAB webinars are always kind of packed with doctors from all over the world, and it's great to see that And we always enjoy this bit where we give you a shout out. We get to hear where you're from. I think what we'll do, though, we are 6 minutes in now. So Dr. Mo, lots of people have signed in already. So I'm going to hand over to you to make a start on hyponatremia. If you're joining us live on the YouTube channel, if you do want to ask any questions, there's a live chat box on the side of your screen, so you can type into there and we'll keep an eye on that. For Zoom, guys, there's a chat button and there's a Q&A button. The Q&A button is the one you want to use if you've got a specific question based on the presentation. Obviously, you can use the chat for smaller conversations, and we'll post some useful links in there for you as well. Over to you, Dr. Mo.
So Vika, so I assume you can see my screens because I've got a split screen.
Yeah, I can see your screen, yeah.
Okay, good. Okay, welcome guys. My name's Dr. Mo. I'm one of the co-founders of Inspire Medics, or iMedics as we are mostly known as. And I've been a doctor now for about 10 years in the United Kingdom. So we're going to be covering the latest UK medical guidelines specifically for electrolyte disturbances, hyponatremia and hypercalcaemia. And of course, it's going to be very, very relevant for those of you who are sitting PLAB 1, but also very relevant for PLAB 2, because you may get a scenario where you get a result station with an electrolyte disturbance. As you may be aware, we have a set format for these webinars. They're approximately 1 hour long, two topics that we cover, and we try and cover the key points, the things that are most likely to be tested on the day of the exam. And for that reason, I normally cover 3 or 4 key learning points, and similarly to Dr. Sandu, he tries to cover the key learning points that are going to occur or be expected to be known on the day of the exam, whether it be PLAB 1 or PLAB 2. So I'll be covering hyponatremia, which is obviously an electrolyte disturbance to do with sodium. And then Dr. Sandu will be covering hypercalcaemia for the latest UK NICE guidelines. So for those of you who are not familiar with the NICE guidelines, most UK doctors refer to the NICE guidelines when managing a patient or checking up on information related to latest medical content. Because NICE updates their guidance usually on a monthly basis for various different topics, and there's over 500 topics covered on the NICE website. So let's get started because there's a relatively fair amount to get through. So let's do a recap for those of you who obviously recently exited medical school. This will be relatively familiar, but for those of you who went to medical school perhaps 3, 4, 5, maybe more years ago, there are some key bits of information we need to recap. So this is information you should already know. And the normal sodium concentration or serum sodium concentration is between 135 to 145 millimoles per liter. That's the UK threshold. Now, hyponatremia is obviously low sodium, and so the threshold, or the cutoff of the threshold for hyponatremia is less than 135 millimoles per liter. However, in the United Kingdom, we classify hyponatremia into mild, moderate, and severe classifications. And there are, again, our thresholds that we cut off at for these, and you want to be remembering these thresholds as the rule of 5s. So between 135 to 130, that's considered mild hyponatremia. From 129 to 125, which is roughly 5, is moderate hyponatremia, and then below 125 is considered to be severe hyponatremia. So those are the key things you need to remember in terms of the classifications of hyponatremia, and just remember the rule of 5s in case you forget on the day of the exam. Now, another recap. So we're going to cover some basic physiology here. Again, it's just to recap the information that you would have already learned in the past. So the first thing you need to know about is that there's a chemical or hormone, more specifically, called ADH, also known as vasopressin. Now, this is produced by the hypothalamus, and it's stored in the posterior pituitary gland. And when it's released into the bloodstream, it affects the kidneys, and it increases the reabsorption of water by the kidney. And that's important to know because ADH is closely related to serum sodium concentration levels. And we'll come on to that shortly. Now, why is hyponatremia so important? Why as doctors should we pay attention to it? Number one, it's the most common electrolyte disturbance that we see, not only in the UK, but most likely the world. And also severe hyponatremia can result in cerebral edema. And that's important to know because that can be potentially life-threatening. untreated severe hyponatremia can result in seizures, coma, and eventually death. And so it's very, very important to obviously know your thresholds, but also know the consequences of untreated hyponatremia, which continues to get worse. So like I said, that's a recap. Let's go into the actual learning in terms of the things that you may be tested on. So there are different classifications of hyponatremia. We've obviously covered mild, moderate, severe. There's acute and chronic. So usually that's related to whether or not it's been going on for more than 48 or less than 48 hours. But there's also classifications in relation to the tonicity of the water. So hypotonic, hypovolemic, euvolemic classifications. So I'll break those down into specific areas, and I'll cover those one by one. So let's start off with hypotonic hyponatremia. So what does this mean when you have hypotonic hyponatremia? So the reason this classification is important is because you can categorize different causes into these classifications. So hypotonic hyponatremia is when you get volume depletion. So the way to think about it is you lose fluid from the body, but because you lose fluid from the body, you also lose salts effectively. So you lose sodium. And as a result of that, your sodium concentrations begin to drop. And the obvious ones are if you have diarrhea or vomiting, for example, if a patient's taking diuretics, and also Addison's disease can also cause hypotonic hyponatremia. Think of it as volume depletion, and that's the best way to remember it. Then we have hypervolemic hyponatremia. And as the hypervolemic terminology suggests, this is when you get volume overload. Certain conditions cause volume overload. These conditions are heart failure, liver failure, kidney failure, and you're thinking about edemic type conditions which cause or are related to edema. So what's the pathophysiology here? So here you get volume overload. So there's too much fluid or water in the body. It dilutes the sodium and it causes the sodium levels to drop. So that's hypervolemic hyponatremia. Then you have euvolemic hyponatremia. This is where overall what happens is the volume increases in the body of water, and as a result, the sodium concentration levels get diluted, and that results obviously in a low sodium concentration. And euvolemic hyponatremia can be caused by drugs, for example, SSRIs, but also by conditions which will fall under the banner of SIADH, syndrome of inappropriate ADH release. So that's another classification. And again, it may get tested on in PLAB 1. Now, you do need to know about common causes for hyponatremia. That's the topic area most likely to be tested on for PLAB 1 and PLAB 2, because you may be counseling a patient in PLAB 2 about why they may be hyponatremic and what management options you would implement in order to correct the electrolyte imbalance. So what are the most common causes of hyponatremia? Common drug causes. So diuretics, specifically thiazide diuretics, are one of the most common culprits in this condition, but also obviously loop diuretics or any other diuretics that you may be prescribing or the patient may be on. SSRIs, so an example of SSRIs include fluoxetine, citalopram, escitalopram, sertraline. SSRIs are very, very commonly prescribed in the United Kingdom for anxiety and depression. Then you have antipsychotics, examples being haloperidol and phenothiazines, and also anti-epileptics like carbamazepine, for example. Then you have less common drug causes of hyponatremia. And I've broken these down into 3 categories: the blue category, the red category, and the black category. And the reason I've done that is because there's specific physiological reasons for why hyponatremia is caused by those specific drug types, depending on their color classification. So, for example, opioids, ACE inhibitors, PPIs, anticonvulsants, amiodarone, theophylline, dopamine antagonists, antidiabetics like insulin and tolbutamine, NSAIDs, and MDMA, which is ecstasy. Very common question in PLAB 1. You may get an electrolyte user needs which come up. Patient has overdosed on a illegal drug. What is it most likely to be? And if it's the patient's hyponatremic, it's likely to be ecstasy, also known as MDMA. Those drugs there affect hyponatremia or sodium levels in one way. And I would like you to type into the chat box what pathophysiology you think those drugs affect sodium levels. So if you'd like to go ahead, type into the chat box what pathophysiology the blue drugs, the drugs in blue, are likely to affect sodium levels. Then we have NSAIDs, and NSAIDs can cause hyponatremia, but more often in combination with thiazide diuretics or if the patient's got concurrent heart failure. And then, of course, you have desmopressin or oxytocin. So before I move on to the next slide, would you like to type very quickly, just type into the chat box in Zoom, what you think the pathophysiology of the drugs in blue is? So it's going to give it 20, 30 seconds. You'd like to type into the chat box what the pathophysiology of causing hyponatremia for the drugs in blue is. So somebody's written, I'm afraid the full name hasn't come up on my screen. YK affects sodium absorption at the renal tubules, effects on bowel movements and osmotic things. That was your Vita. Okay, how about the NSAIDs? How do you think NSAIDs affect hyponatremic levels at the pathophysiologic level? So if you want to quickly just type into the chat box, and then of course, we'll then move on to the last one, and I'll give you the answers. So Mohammed wrote efferent arterial vasodilation. Okay, good. And then finally, how do you think desmopressin or oxytocin affect hyponatremic levels? What's the pathophysiology? If you want to type into the box, and we'll move on to the next slide. Andrew says vasoconstriction afferent. Okay, let's move on to the next slide. Some interesting answers. So the drugs in blue actually increase the production of ADH or make it more potent. And those, as I said, were opioids, ACE inhibitors, PPIs, anticonvulsants, amiodarone, theophylline, dopamine antagonists, antidiabetics like insulin and tolbutamine, NSAID drugs, and NMDMA. But NSAIDs can also cause loss of ADH inhibition, which effectively is SIADH. And that's why that particular drug was colored in red. And then the drugs that were colored in black font actually are exogenous ADH. So you're taking ADH from an external source from outside the body, and if you put it into the body, of course, it can have a hyponatremic effect. So desmopressin and oxytocin are two good examples. So it's important to be aware of this, because you may be able to obviously spot the reason for why a patient's sodium levels are dropping. And of course, you've got don't forget the common and the less common causes. Now, how do you manage low sodium or hyponatremia? Now, the management slide that we've provided you with is for the NICE guidelines for patients who are in the community. So that if they're in a GP setting, not a hospital setting. In a hospital setting, obviously, you would implement some of these findings, some of these management strategies. But in a community setting, you may also have access to IV saline, which would contain, for example, 0.9% normal saline sodium chloride. And there's different ways, obviously, correcting hypovolemia. Hyponatremia. Now, in a hospital setting, you would usually carefully correct hyponatremia, especially if it's moderate to severe, because if you correct hyponatremic levels too quickly, you can actually start to cause patient side effects, and they can start to experience unpleasant symptoms. And so in all hospitals in the UK, there will be guidelines on how to correct hyponatremic levels in a patient safely and also effectively. So as always, refer to the local hospital guidelines on how to correct. But overall, you'd see something like this in the hospital guidelines. If the hyponatremia is mild, so 130 to 135, in a situation like that, you ideally want to stop any medications which may be exacerbating that effect of the low sodium levels. And we did cover this in the first 2 or 3 slides. But you also, more importantly, want to repeat the user-knees. And the reason for that is it may be a one-off result. It may be that it's corrected itself on the repeat, or you may start to notice a trend, i.e. it's getting worse. With regards to moderate hyponatremia, so 135 to 130, ideally in the community, you want to be discussing that with the endocrinology team just to get more further advice. And of course, you'll be stopping any medications associated, and of course, you'll be repeating the user-knees. But at that point, really, you want to be getting senior input before you start implementing a management plan. And the same applies if you're a PLAB 2 doctor in a PLAB 2 station. If you get moderate hyponatremia, your management plan would be A, to repeat the use and ease, B, to stop any medications which may be exacerbating or causing the hyponatremia, but C, you'd be discussing it with a senior colleague or the endocrinology team. And then finally, if you're in a PLAB 2 scenario, or if you get a PLAB 1 question where the hyponatremia, the sodium levels are below 125, you are admitting that patient, because it's very, very likely that that patient starting to become symptomatic. And obviously, if the sodium levels continue to drop, don't forget it can result in coma, seizures, and of course, death. So broadly speaking, this is how you would manage hyponatremia in a UK setting. Now, what I'm going to do is, of course, give you the opportunity to ask questions, but I'm also going to recap the information that's been provided. So first of all, what's hyponatremia? It's a serum sodium concentration level below 135. It's classified into mild, moderate, severe. Remember the rule of fives if you want to remember what the cutoffs are. So 130, 125, and below 125. Then you have the physiology we covered. It's obviously the serum sodium levels are regulated by ADH. And why is it important? Because severe hyponatremia can result in cerebral edema, very common PLAB 1 question, which can sometimes come up, which can result in death. The other classifications are acute and chronic, but the other one to know about is hypotonic, hypovolemic, and euvolemic hyponatremia classifications. The most common things that are tested on in the PLAB 1 and PLAB 2 exam for hyponatremia are drug causes. You have the common drug causes. I would definitely remember this slide, but then you have the less common drug causes. Less so, you don't really need to remember the pathophysiology, but of course it helps. And we've broken it down to classifications to aid your memory. And then, of course, how do you manage hyponatremia? So it depends on the severity of the hyponatremia, which is why we covered mild, moderate, severe classifications at the beginning. And depending on the severity of the hyponatremia will determine your management plan. So that, in a nutshell, is how you manage hyponatremia, why it's so important to monitor and manage hyponatremia effectively, and of course, how to implement different management plans depending on the classification of the hyponatremia you've come across. The other thing to remember is hyponatremia is relatively more common in an elderly population. If you start to see hyponatremia in a younger population, you're thinking about conditions like Addison's disease, possibly has the patient overdosed on a drug like ecstasy. So again, factor that into your assessments, whether it be a PLAB 2 scenario or a PLAB 1 exam question that you have. So what I'd like to do, guys, is I'm going to pause it there to allow you guys to ask any questions. And in the meantime, what we're going to do is I'm just going to share a couple of URL links for you that you may find useful. So number one, firstly, a quick show of hands. Who here is sitting PLAB 1 in the next 3 to 4 months? Just raise your hands if you're sitting PLAB 1 in the next 3 to 4 months. Okay, so 5, 7. So in Zoom, there's a feature where you can raise your hand. Have a quick look on your devices. Just raise your hand. So 10 people are sitting PLAB 1 in the next 3, 11, 12. 12 people. So Nufa, Niha, Abinaya, Yoshiki, Daniela, Salome, Oliver, Oguchukwu, Rahimat. Okay, there's a couple of names that I've shouted out that are sitting PLAB 1, so PLAB 2. So for those of you who are sitting PLAB 1, a couple of things I'd like to highlight. Number one, we've got a free PLAB 1 question bank, completely free, no charge. 3,000 questions. You can use it for as long as you want. All you need to do is click on PLAB 1 free, choose 12 months, add to cart or free checkout, and it'll be added to your account. Once it's added to your account, you'll see your account page, which looks like this. And then you can go into your PLAB 1 online questions. And then from there, so you guys, you can lower your hands, those of you who've raised it. And then, of course, you can choose the topic area that you want to choose to answer the questions on. Don't forget, we've got review questions down at the bottom. You can review the questions that you've already answered. We've got a score tracker feature, and we've got game mode as well. So worth exploring those. And if you find that you're weak in particular topics, like let's say hyponatremia, there you go. I can pull out all the questions for hyponatremia for all the different categories, press start, and I will now be doing all the questions that are relevant for hyponatremia. So which one of the following is most likely to be caused by burns? I'm just going to choose one answer. Dr. Mo probably will get this wrong. I've randomly chose it. And of course, you've got the nice guidelines underneath to give you information. It's a very, very smart, effective, cost-effective way of revising for the PLAB 1 exam. For those of you who want to go a little bit further, either you've failed the PLAB 1 exam in the past, or you feel like you need more preparation, you want because you don't have enough time, or you really want to make sure you pass first time, we have the PLAB 1 Gold package. So what does the PLAB 1 Gold package contain? It contains 750 further MCQs in video format. It contains 750 revision podcasts, so all the nice guidelines summarized in podcast format, so you can listen to it whilst on the way to work, on your weekends, when you're perhaps going for a jog or to the gym. And we've also got 750 mini teaching videos by me and Dr. Sandhu. And we also include some free flashcards, which we send out to your home address for revision for the PLAB 1 exam. So if you need a bit more, if you need some boosting to your score, PLAB 1 Gold package, it's don't pass, don't pay, which means that if you fail the PLAB 1 exam after you've subscribed to the PLAB 1 Gold package, we will refund you your money. What does the PLAB 1 Gold package look like? So it looks something like this. I'll just show you. So this is my account. I've got everything in my account because we have to test it on a regular basis. But this is what the Gold package looks like. You have the podcasts here. You have the watch the videos here. I'll just go into the videos just to show you what they look like. So if I go into the videos, you can see over 750 videos down here at the bottom. You can see 750 videos down here at the bottom. You can scroll across, and they're broken down into different topic areas. The cardiology question 12. You can watch a question about statins. So that's, and then the other product for PLAB 1, which is very interesting, is our PLAB 1 mock, only $29.99. Next one's on Sunday, 1st of August, between 10 a.m. and 7:30. Basically, we do a live mock, 3 hours, 1 hour lunch break, and then 6 hours of teaching with the latest nice guidelines for the UK medical guidelines. Only £30, very, very highly recommended. So quick show of hands, guys. Who of you are sitting PLAB 2 in the next 3 to 4 months? Just raise your hands. Next 3 to 4 months if you're sitting PLAB 2. So we've got 4 people: Naila, Yavita, Harini, Tayi, Samaya. Just raise your hands if you're sitting PLAB 2 in the next 3 to 4 months. Maida. Yep, keep them raised. So Blundelli. Okay, good. So I'm assuming that so the rest of you guys are sitting PLAB 1 or PLAB 2 later on in the year. Fair enough. Okay, for PLAB 2, just to let you know, we have the PLAB 2 video course. 100 videos of common scenarios. So things like SIMMAN, breaking bad news, result stations, counseling a patient, diagnosis, examinations. So hundreds of videos recorded by me and Dr. Sandhu, 1, 3, 4, 6, 12 months. I would definitely check it out. Dr. Sandhu will include those links in the chat box. We've also got PLAB 2 notes and cases. So what's this about? What are PLAB 2 notes and cases? This is the examiner's mark sheets. So you can see what the examiners are looking for when they're assessing you. And then also you get the actual scenario itself. So you can see what the scenario is, and you get nice guidelines at the same time. So highly, highly recommended. Only $14.99. You get 100 cases with examiner's mark sheets. We also have the podcast. So if you want to buy the podcast separately to listen to, you can subscribe to these for 1 to 12 months, only $29.99. And for those of you who feel like you need something to boost your score for PLAB 2, like you want to really go for the top marks, or you want to pass first time, PLAB 2 Advanced Communication Skills course, and mocks. We do live mocks within it, full day course. It's don't pass, don't pay. We're so confident in this course because it's taken us a long time to develop it. We've included all the tips, strategies, methods, and things that we've noticed that top scoring PLAB 2 candidates do. And we teach you that within a full day course. And we cover 5 key domains, 10 key topic areas, me and Dr. Sandhu. $149.99. It's on a Sunday between 10 to 5 p.m. It's jam-packed with information. And if there's one course that you must go on that you're going to look back on and think that's the best money you've ever spent, it will be this course. So please do subscribe to it. All you need to do is choose the date. So if I just choose the date on the 4th of July, add to cart, and then you can check out. And of course, it's don't pass, don't pay, which means if you fail the PLAB 2 after you subscribe to this, we will refund you your money. And then, of course, the last thing we have, or the last 2 things, is the PLAB 2 mock. So if you want one-to-one practice with me and Dr. Sandhu, or UK doctors, we'll do PLAB 2 mocks, $54.99 for 1 hour. Highly recommended. There's high demand for the PLAB 2 mocks because the price point's actually really nice. So please try and book early if you can. And then finally, I know I'm rabbiting on, we've got the PLAB 2 coaching, which is one-to-one coaching to really dig into what you're doing wrong to improve your score to help you pass, and you can book in for 2, 3 or more hours. And finally, this as a passing note, we do UK visas as well. So if you're struggling to get a visa or need a UK legal firm to represent you for tier 2 or visitor visas, we have the visa packages as well. So what I'm going to do, guys, is just going to pause it there for a moment. I think some of you had questions, so let's see. So Yovita, could you repeat the pathophysiology for drugs in red? Yes, we can. It's going to bring it up on the screen for you. So there you go. There's the answer, Yovita, that you've asked for. Let's have a look at some of the other questions. So Innocent, I've seen your comment. I'll come on to that very shortly. Effect on bowel movements and osmotic things. So obviously if you've got diarrhea, and if there's a laxative effect on bowel movements, which can cause diarrhea, then you are going to lose salts. So that's going to be a hypovolemic hyponatremia, and that, of course, will result in low sodium. How would you know? So this is a question from Hajira. How would you know if the patient is suffering seizure due to epilepsy or hyponatremia? Hajira, very easy, very good question, but very easy way of determining that. When you get a patient who's an epileptic and they have an epileptic seizure, it's important that you correct any reversible causes. So you do using these FBC, LFTs, maybe a clotting profile, and a magnesium, serum magnesium levels as well. If you notice hyponatremia, you must assume that it may have played a role in the seizure for the epileptic patient, and therefore you must correct it. You mustn't assume automatically it's because of the epilepsy, because remember, epilepsy can sometimes be triggered by physiological causes. So you would obviously make sure you do your bloods and assume that hyponatremia has been one of the possible causes of the seizure in an epileptic patient. Okay, other questions that we have. Mohammed, we're not on Spotify yet for the podcast. We are going to be on Spotify at some point in the next 2 to 3 weeks. So iMedics is launching our own podcast profile. We'll be on Spotify, Apple iTunes, Google Podcasts. We'll be on a lot of the big platforms, and we'll be talking about different topics. So do keep an eye on that for that. We'll send out an email, so please don't unsubscribe from your emails from iMedics. Let's see, what else do we have? So Mary says, don't we need to learn how to manage and treat severe hyponatremia? Mary, yes, you do. We've covered the community guidelines today. Normally with severe hyponatremia, you're correcting the serum sodium levels slowly. So you're aiming, for example, for a serum sodium level of a certain amount to be increased over a certain period of time. Now that varies from hospital to hospital, and you want to go to the main NICE guidelines to look into that. Today we've covered the community guidelines, but often you'd be doing this based on senior input. So it's very, very unlikely that you'll be tested on the specifics for hyponatremia, severe hyponatremia management in terms of the rate of a sodium infusion, sodium fluid infusion that you may have to do. But of course, you need to know how severe hyponatremia is managed. And of course, the patients do get admitted. Let's see what else that is here. Okay, so I think the last thing I'm going to touch on is Innocent's comment on in the Q&A. So you didn't mention TURP syndrome. So TURP syndrome is, of course, a cause of hyponatremia. So this is a transurethral resection of the prostate. Often you get a lot of fluid pumped into the bladder as a washout during the TURP procedure or after the TURP procedure. And that can be a common complication of TURP, which is you can develop hyponatremia. So Innocent, well spotted. And of course, there are lots of different causes for hyponatremia, but we've focused on the drug causes today because we don't want to overload you with information. Because of course you can have a read of the NICE guidelines and go into your textbooks, but we're going to cover the things that are most likely to be tested. But you're right, TURP can come up as a PLAB 1 question. So well spotted, Innocent. Okay, guys, what I'm going to do is now bounce over to Dr. Sandhu, who'll be covering, I think, is that Innocent who's come up with a long list of
that was me. I've just put that in. So okay. A question about signs and symptoms of hyponatremia. So if you just let me share the screen, and then I can move on to the next presentation. Perfect, guys. So we'll move on to your second presentation. So Dr. Mo's obviously talked about hyponatraemia, another relatively hot topic that you should be mindful of for PLAB1. And it's also important to know, so you've got your knowledge up to date if you're preparing for PLAB2, is hypercalcaemia, which of course is a raised calcium level. So we'll focus on some of the key things, as we always do in hypercalcaemia, going through the structure that I tend to have in my presentation. So many of you have probably been part of my presentations before, so you know we tend to have a structure. That structure will include a definition, focusing on the causes of hypercalcaemia, the key clinical features, how we diagnose, and of course, how we manage as well. So how do we define hypercalcaemia? Well, basically the current NICE guidance will define, now this can vary by the way, depending on where in the country you practice, but you go with the NICE guidance, which is the national UK guidance. Hypercalcaemia is basically when the calcium concentration in the serum is 2.6 millimole per litre or higher, and that's done on 2 occasions. So this number may vary very subtly, but generally you're looking at 2.6 or higher, and it has to be on 2 separate occasions. So we need to think about what are the actual causes. So if we get this lab finding, which you can do as a result station for PLAB1, or you might do, for example, if you're managing someone who needs admission in PLAB2, is thinking about what the causes are. Now, the commonest cause is actually a condition called primary hyperparathyroidism. So you may have heard of this. You've probably seen it when you did your endocrinology block or general surgery block. This is the commonest cause of hypercalcaemia. And normally what you'll find is that patients tend to have kind of an asymptomatic, so they've got no symptoms. We just find that their calcium is slightly raised on a blood test. And that's because they've got either too much an inappropriate secretion of the parathyroid hormone in the neck, which comes from the parathyroid glands. And that increased parathyroid hormone then interferes with the regulation of serum calcium. It will basically cause increased bone resorption and also more renal calcium reabsorption from the kidney, and indirectly will also increase intestinal calcium absorption as well. So you can understand that that parathyroid hormone is stimulating the calcium from the bone, the kidneys, and the intestine, and so you've got more of it in the system. If you dive into that more, what we tend to find is that actually parathyroid adenomas, so these tiny tumors within the parathyroid gland, tend to be the cause in approximately 85% of cases that we see. And then you can get hyperplasia. So the physiology, when you get the hyperplasia, is a term to describe like cells that start to divide rapidly, and that can happen in the parathyroid gland, and that can then stimulate this process here, and that can lead to hypercalcemia. So that's a bit of background. The second commonest cause is actually cancer. Now, this is very important because when you do see patients with a malignancy, with a hypercalcemia, you need to be thinking about an underlying cancer if parathyroid hormone has been ruled out. And that's because what we then have to think about is we need to take a history and work out, is it a GI cancer? Is it a myeloma? Is it a bowel cancer? And so you ask your relevant screening questions like, have you lost weight? Have you had problems with swallowing food? Have you noticed your bowels have changed? Have you noticed any blood in the stool? Those kind of questions. The physiology, so they believe that the parathyroid hormone, there's a secretion of a parathyroid hormone related protein, and that's basically kind of secreted, and that stimulates the kind of excess calcium to be kind of, stimulated, as we mentioned in the previous slide, from the bone, the kidney, and the intestine. And then 20% is because the cancer's probably spread to the bone. So if, for example, it might be a myeloma that's spread to the bone, that's causing breakdown of the bone, and therefore you're getting calcium being released. And you can see that, as I mentioned, in myelomas and also breast cancers as well. Of course, there are other cancers that can metastasize to the bone as well. Then you've got medication. Now, there's a few medications that you should know of. I mean, there's going to be maybe hundreds if you looked in the BNF, but the key ones to be mindful of, one of them is the thiazide diuretics. And what they do is they basically reduce the amount of calcium that's excreted in the urine, so you've got more of it in the system. And the calcium levels will normally come back to normal when we stop the thiazide medication. So in the UK, and maybe in other parts of the world, so I know some of you guys are joining us from different parts of the world. In the UK, we tend to use a drug called bendroflumethiazide, but actually it's more given in the older population because they've been on it for very many years. And so they haven't come off it because their blood pressure has been controlled. Sometimes, I've seen some cases, I think people have it for edema as well, but normally it was an old blood pressure type medication, but because they've stayed well on it, they've never really come off it. We tend not to give it as much now. We've got newer thiazide-like diuretics like indapamide and chlortalidone. But if you do see patients on that, you can obviously stop that, recheck the calcium, and normally you'll find it will return back to normal. Lithium, which is obviously the drug that we see in psychiatry, which is given for people with bipolar disorder and mania. Lithium basically stimulates the parathyroid hormone secretion directly, and that again causes increased calcium to be reabsorbed, especially from the kidney. And also it makes the kind of, the lithium actually decreases the sensitivity of the calcium receptors. And again, you know, it's a kind of trigger, and it can actually mask as well an underlying primary hyperparathyroidism. So obviously we always check for these kind of cases. Vitamin D is another one. So in the UK, we tend to give vitamin D. Some patients may come in complaining of feeling tired all the time, so you do a blood screen, and often vitamin D is low, and that's because we get very little sunlight for long periods in the UK. Darker skin tends to absorb less vitamin D from the sunlight, and so what you find is that basically is caused, the hypercalcemia in this case is caused because we've given them too much high-dose vitamin D, or they've even had too many topical applications of a potent vitamin D analog. So if you think about vitamin D analog, topical vitamin D, you use it for psoriasis and things like calcipotriol. And if you've kept patients on that for long periods of time, then some of that vitamin D can absorb through the system and trigger off a hypercalcemia. Vitamin A, very rare. I mean, it's not something that I've given before. It's probably more something some patients may take over the counter, but you can get some hypercalcemia if we have too much vitamin A in our diet over a few weeks. And vitamin A toxicity can cause things like hair loss, liver problems, and dermatitis of the skin. Calcium, which is often prescribed alongside other drugs like antacids. So you have to be careful if you're going to prescribe calcium in the long term. And then obviously you can get kind of impaired kidney function. So, you know, if you've got renal failure and the kidneys are not working properly, the calcium is being reabsorbed back into the system, and metabolic alkalosis are another additional factors to be mindful of. Then you've got granulomatous diseases. So this is another segment of causes of hypercalcemia. So you've probably seen classic cases of sarcoidosis, you know, where you've got someone with exertional shortness of breath. Sometimes they get erythema nodosum on the shins. And actually a classic feature in the history is they've got a raised calcium. Tuberculosis, so, you know, someone who's traveled abroad in a high-risk country, they may have night sweats, fevers, a productive cough, hemoptysis. Again, you may find raised calcium. And then other infectious diseases like leprosy, histoplasmosis, and candidiasis. And of course, for kidneys, so we touched on the kidneys before. So someone who's got chronic kidney disease or chronic renal failure, sometimes the low levels of calcium that are being secreted can cause hypertrophy. So the parathyroid gland starts to get bigger in size, and we call that a secondary hyperparathyroidism. In tertiary hyperparathyroidism, that's when you've got this hypertrophied gland. So in other words, the gland is increased in size, and it starts to produce a large amount of parathyroid hormone at random by its own. It's got a mind of its own, and that starts to cause, you know, more calcium to be reabsorbed from the kidneys, from the intestine, and from the bone, and so we get hypercalcemia. So that's your tertiary hyperparathyroidism. It's basically when you get this random, sporadic secretion of the parathyroid hormone. In sort of more end-stage renal problems, some of the patients, of course, will be on dialysis, and there may be treatment with calcium and vitamin D analogs, and that, if we over-treat them, may lead to hypercalcemia, and that's why we have to monitor their bone profile. Renal transplant patients, again, they may have hypercalcemia because they've got a pre-existing underlying parathyroid hyperplasia, and so it's important to be mindful of that. After acute kidney injury, so acutely unwell patients who may be severely dehydrated may get acute kidney injury, and so hypercalcemia may result because of a rebound increase in levels of parathyroid hormone and vitamin D. And of course, if the acute kidney injury was caused by rhabdomyolysis, so rhabdomyolysis is a breakdown of skeletal muscle. You may see this in an elderly patient who's fallen and wasn't able to call for an ambulance for many hours. And so obviously their muscle started to break down, and you can get what we call Coca-Cola urine, so like a cola-colored urine. And in these cases, hypercalcemia can occur because that calcium's come out of the muscle and it's gone into the system. So just a couple of other important causes to be mindful of. Very rare, but there's our genetic conditions as well. You can get familial hypocalciuric hypercalcemia. It's a very rare benign autosomal dominant disorder where there's a mutation in the calcium sensing receptor. And so the body is just generally not sensitive to calcium, so it doesn't regulate calcium levels properly. And so we find that the levels increase in the body. It could be that you have a mild raised calcium on the blood test. The patient normally doesn't have any symptoms. They may have low phosphate, or they may have kind of normal or slightly raised parathyroid hormone levels. Often it can be present from birth, but sometimes we just spot it incidentally later on in life in someone who doesn't have any symptoms. You're just doing a blood test for something else and you spot this. Immobile patients, so people who are immobile will have an accelerated bone turnover, such as Paget's disease, for example, and that's something to be mindful of as well. And that's because there's increased osteoclast activity. Osteoclasts break down bone, and there's a reduction in osteoblast activity, the blasts that actually build the bone. And again, therefore, that leads to excess calcium in the body. You've got non-parathyroid causes, so other endocrine things to be mindful of. So raised thyroid, so thyrotoxicosis. So remember, when people have hyperthyroidism, they've got things like, they're very hot all the time, weight loss, diarrhea, palpitations, tremors, and that's basically increased osteoclast activity. So those osteoclasts start to break down the bone, and that causes, of course, more calcium in the system. Addison's disease, and that's because there's increased calcium absorption from the bone, and also there's some dehydration which can occur as well. Pheochromocytoma, so remember, you get kind of abdominal pain, chest pain, palpitations, really sweaty, really headache, often a high blood pressure as well. Abdominal pain, these are things that you can get in this condition. And that's thought to be because there's a parathyroid hormone type peptide that's produced, and that can stimulate the kind of excess calcium in the body. And very rarely you can get a VIPoma, which is a type of islet cell tumor. So it's very, very rare to be mindful, but you can see this. So from a PLAB1 perspective, you've got a hypercalcaemia, but the clinical features will include like diarrhea. So that the stem might mention a patient who's got diarrhea and a low potassium. So hypercalcaemia, low potassium, and a diarrhea would be very rare, but a very special question to ask if they did in PLAB1, and you'd be thinking of a VIPoma. So a couple of things to think about. What are the key features of the condition? So remember, there's a mnemonic, there's bones, stones, groans, and psychiatric overtones. So I've included them in the presentation. When we mention bones, we talk about kind of aches and pains, and there's obviously a risk of fracture. When we talk about stones, that raise calcium puts you at risk of kidney stones. Groans, so patients can complain of abdominal pain, constipation, nausea, and vomiting. And the psychiatric overtones, so often patients with hypercalcemia can be lethargic, can be low, and very rarely can go on to get psychosis. This is why psychiatrists ask you to do a blood test before you refer the patient to them, so you can rule out an underlying reversible cause. So we touched on diagnosis earlier. So remember, it depends on the lab, but the mild hypercalcemia is when the calcium level is between about 2.6 and 3. A moderate hypercalcemia is when the level is between 3.1 and 3.40. And of course, a severe hypercalcemia is classified as a volume greater than 3.40. For someone who's got severe features, it's a hospital admission, and I'll talk about the management in a minute. For someone who's asymptomatic or has got very mild or moderate hypercalcemia, the NICE guidance says you check the calcium level again after one week to confirm the diagnosis. And if someone has got mild or moderate hypercalcemia on that repeat testing after a week, then we should do some further tests. In GP, for example, GP should do some further tests to determine any underlying cause, depending on what kind of clinical features the patient has. For example, if you thought sarcoidosis, you'd get a chest X-ray. Naturally, you would have checked their kidney function. You'll probably do a parathyroid hormone level as well, vitamin D, and so forth, to see if you can look for an underlying cause. Management. So for severe hyperkalemia, remember, it's admission. So the patient needs to be sent to hospital on the same day. They'll be given IV fluid rehydration, rehydrate the body, rehydrate the kidney, and they get IV bisphosphonate therapy. So drugs, the commonest two are pamidronate or xalindronate, to help steadily reduce the calcium level in the body. If someone is asymptomatic with minimal symptoms, with mild or moderate hypercalcemia, as we mentioned before, we look for an underlying cause. If we find that, or we worry that it could be a cancer, you can make a 2-week wait referral to a cancer clinic, depending on which cancer you think is the most likely cause based on the history and examination. And if you think that it's thyroid or endocrine, like Addison's disease, then you refer them to an endocrinologist for further assessment. couple of things to be mindful of. So vitamin D in the UK is often given. This is a bonus learning point. So we often give vitamin D supplements. We do, someone who comes in tired all the time, we check the vitamin D, it comes back low. We put them on high dose treatment normally for 6 weeks in the UK. The NICE guidance says you need to then check the calcium levels after the treatment is completed. And normally if the calcium level is kind of, if there's a normal calcium level, then when you check it after the vitamin D treatment is completed, you don't need to give them long-term calcium supplements. And likewise, if there's low calcium, then obviously you should recommend that they try some over-the-counter supplements. So perfect. So that takes us to the end of your session. So over to any questions that may be on across the board. I think Dr. Mo is adding some stuff in there as well. All right, okay, so I think Dr. Mo's just typed some stuff in there. So perfect, guys. So any questions on hypercalcemia? Quite a difficult topic, busy topic, but this webinar, by the way, is still going to be available on the YouTube channel, so you can watch it back if you're worried about seeing it again. And of course, we will email it out to you as well. So I don't think there's any questions that are propped up. Just very quickly, what I'd like to show you guys is give you a quick snapshot of our. If you're preparing for PLAB 2, we've just introduced a brand new video series. So it's patient information leaflets. I'm going to put the link in now for you. So this is what it looks like. This is a YouTube video. It's the first one that we've put up on Friday. And it's called What is Type 2 Diabetes? Now, these videos are going to be going up in the next few weeks. They're very visual and they're very to the point. And the reason we mentioned it for PLAB 2 is because when you do your explanations in PLAB 2, you need to keep your information very simple so you get the top marks. So do watch these videos. We've got more ones. The second one is going to be acute prostatitis. That will be ready in the next few days. And there's going to be lots of different videos coming up in the next few weeks. So they're going to be focused for you guys, especially for those preparing for PLAB 2, simple 60-second videos with lots of visuals. I've put the link in down below. And also you can use it for your patients. So if you've got patients in clinic and they want to know what is type 2 diabetes, Dr. Sandhu, I don't know. Well, I can say, well, Mrs. Smith, have a look at this video. It will explain what the condition is, how we diagnose it and how we manage it and some of the complications, but in a very short and easy to understand way. And we will, like I said, be putting more of them up for you in the coming weeks. So you'll see lots of these videos. So do like and subscribe and obviously share those videos with your medical school and your colleagues on YouTube, and do follow our YouTube channel as well. So let's see if there's any questions that are propped up while we've got that. So some nice comments coming through. Appreciate that, guys. So Andrew Jackson, really good. Thank you. And Nufa, thank you. Really well organized. And then you've got good question. So tertiary hyperparathyroidism is basically an autonomous, random kind of, it's where the body basically starts going on its own kind of tangent and just basically starts to randomly produce raised calcium. Secondary, if you go backwards, is normally when we have when someone's got chronic renal disease and actually their calcium levels are low. And so the gland itself undergoes hypertrophy. And then, of course, the primary hyperparathyroidism is the one that we've already touched on. And that's when we've got inappropriate secretion, which is directly just from the parathyroid gland. So, tertiary, automatic, random behavior of the parathyroid hormone. Secondary, normally chronic renal failure, low calcium, and that stimulates hyperplasia of the gland. And primary is basically excess or inappropriate secretion of parathyroid hormone. And that's a bit of a brief summary there for you. Some nice comments again coming in. So guys, there is a Google review link that Dr. Mo's left. If you did find it useful, it takes literally 10 to 20 seconds to leave us a nice review. We would appreciate that because we do lots of things for free. So the PLAB 1 question bank is free. The videos that we're going to be producing will be free. They'll be on our YouTube channel, helping those preparing for PLAB 2, as well as your clinics when you move to the UK. So do give us a nice review if you can. The link is there. Last thing, I'm just going to put in the social media channels for you so that you know what they are. We're on Instagram, Twitter. We've got Facebook, PLAB 1 and PLAB 2 as well. And I'll just put these links on for you just so that you can see. So don't forget to like, share and follow. There's a PLAB 1 Facebook revision group. There's a PLAB 2 Facebook revision group as well. Lots of revision material going on in there. And of course, you know, do like sort of follow us on those platforms. If there's anything else or any questions that you had, obviously do let us know. Hajira's question is, how long should a student take English test before doing PLAB 1? So Hajira, I would, depending on when you're planning on doing PLAB 1, I would look to get the English test done relatively quickly, but do it within, make sure you set yourself a good deadline. So if you know you're going to sit PLAB in October, for example, then try and get the English test done over the summer, maybe July, August, September time. And then you've got enough time to pass PLAB 1, get your PLAB 2 done, and obviously get all of that done while your English test is still valid. Any more questions that have popped up? Good, perfect. So that's all from me then, guys. So obviously, thank you for joining us. It's been obviously fantastic to have you here. It's been a very constructive session. It's been a very constructive session. And obviously, like I said, do like, subscribe, do join us for some of our up and coming teaching webinars. If there's anything else you want us to do let us know. We're always happy to obviously do some topics for you guys as well. And I don't think there was any questions that popped up on the YouTube channel. Okay, nice comment there. So Siki Shah said, as usual, excellent session. Thank you, sir. Appreciate that, Siki. So some nice comments coming in on YouTube as well. So appreciate that, guys. So over to you, Dr. Mo, for any last words before we wrap up.
Yeah, just one last thing, guys. Our PLAB 1 question bank is completely free. It's got 3,000 questions in it. We're going to build it to 4,000, 5,000 questions. So what we expect to get to is there shouldn't be a question in our question bank which does not have a similar question which comes up in the real exam. That's what we're trying to get to. So if you've seen a question in our question bank, there should be something similar on the real day. The one question I have for you guys now, and I'd really appreciate if you can type into the chat box, is there anything that stopped you from almost subscribing to the free PLAB 1 question bank? Or is there anything that's stopping you or stopped you or almost stopped you from subscribing to the free PLAB 1 question bank in the past? So you may have subscribed to it, but just before you subscribed to it, did you have any thoughts that went through your head that thought, actually, maybe I won't subscribe to it because? And what was that reason? If you had a reason, could you just very quickly type into the chat box? Because what we're trying to do is improve the website. There's a lot of doctors who are sitting PLAB who can't believe that we have a free PLAB 1 question bank. They're like, you tell them and they go, no, it can't be true. It's a big lie. So we're trying to tell lots of doctors, whether they're in Africa, Nigeria, India, no, it is free. And we are going to keep it free. But what's stopping you from subscribing to it? And we'd love to hear your opinions on this. So yeah, somebody thought, yeah, maybe it was a joke. I didn't know it was free. Are there any other reasons? Because we want to really try and fix that and allow as many international doctors. Yeah, so Vikas, if you don't mind, can you share that with Abby?
Yeah, I'll put it in again for you. Yeah. Are you about to do it now?
Yes, it's in there. So I get the impression people can't believe it's free. So if you could really help us out, if you've got friends or colleagues who are asking about PLAB 1, just let them know about iMedics. We're making the question bank better and better. Now, I know there is other big organizations, for example, like Plabable out there. Lots of people talk about Plabable. But what we're going to do is we're going to build a question bank that's going to be A, free, B, that's going to be better than any other organizations out there. So the questions will be almost like the real questions on the day of the exam. And C, there'll be more questions than any other bank there is available. So free, high quality, and also the most questions. What is the link? Favor, that's the link that we've put in, that link. So what you need to do is, once you click on that link, you just choose a free package, choose 12 months and free access now. And it will take you straight to the, it'll take you to create an account. And then once you've created an account, you'll see a page that looks like this. This is your My Account page. Obviously, it looks a bit different on a mobile device. It's mobile optimized. Then you click on the online questions box. And then from there, you can choose, let's say, cardiology, and you can start answering questions. The other thing is, don't forget, you can use the score tracker feature. So the score tracker feature highlights all your weaknesses, and it shows you your score on a monthly, daily basis and which topic areas you're doing well at. And you can see my weakness areas are hyponatraemia. If I click on hyponatraemia, the system will pull out all the questions to do with hyponatraemia, which there are 14 questions. And then the last thing to add is, guys, don't forget to mention this to your colleagues and friends. We're putting a lot of effort into this. It took us 3 years to build up the PLAB 1 question bank. I think it's important that people, as many people as possible, doctors, know about it so they can benefit from it. So that's the last thing I just wanted to add. And I will have another teaching PLAB session now, free webinar, in probably about 4 to 6 weeks' time. Please do take care wherever you are. There is a global pandemic. Some countries obviously hurting a lot because the cases have spiked, India being a good example. But wherever you are, stay safe, you and your families, and we look forward to seeing you and hearing from you soon. And don't forget to leave a Google review if you've got 20 seconds. So it's bye-bye for myself, Dr. Mo here in the UK, and Dr. Sandhu as well.